Please take your seats. So you did quite well with a break. I have not to deduct too much time in the next break. And we can start now with a very important session, number 1, news since 2017. And it's my pleasure to announce Professor Walter Weber, breast surgeon and chief of breast service at the University Hospital in Basel, to give his view on new developments in surgery in the last 2 years. Walter, please.
Thank you very much, Beat, dear colleagues, ladies and gentlemen. It is a huge pleasure to be here to open this session with a talk on surgery, what's new since the last time, 2017. These are my disclosures. I will start by talking about the axilla because I believe it's the more fascinating part, and then I will talk about surgery of the breast. We now have long-term follow-up data of 2 large non-inferiority trials randomizing clinically node-negative patients with limited disease in the sentinel nodes into one group with axillary dissection, and they compared this with the experimental group with no axillary-specific treatment. And as you can see, the rates of axillary recurrence remained extremely low in both arms, with no differences in disease-free or overall survival, making a very strong point that axillary dissection can no longer be considered standard practice in all node-positive patients. C11 has been criticized for various reasons, but enough time has now passed to ask the number 1 question. Does the C11 protocol work in clinical practice? And the answer is clearly, yes, it does. As shown by this prospective validation study from Memorial Sloan Kettering, where they started to implement the C11 protocol in clinical practice in August 2010. I remember this very well because I was a breast surgery fellow at Memorial at the time, hoping to do as many axillary dissections as possible. And for me, it was rather sad that Monica Morrow made us reduce the number of axillary dissections by 50% from one day to the next, right after first publication of C11. So that's when this study started. Now 800 patients have been included, treated according to C11, meaning in patients with CT1 to 2 clinically node-negative tumors, 1 or 2 positive sentinel nodes, undergoing breast-conserving surgery, whole breast irradiation, and some sort of systemic treatment. Axillary dissection was routinely omitted. It was only performed for pre-specified exclusion criteria, again matched to C11, matted nodes, cross-extranodal disease, or more than 2 positive sentinel nodes. This happened 16% of the time with no difference by age or biology. And at the median follow-up of 29 months, there was not a single case of isolated axillary recurrence in that large series. Even though many of those patients received radiation in the prone position with virtually no coverage of the axilla, making the point that many of these patients do absolutely excellent with no axillary-specific treatment, no dissection, and no radiation. Many studies have looked at the impact of C11 on clinical practice. This is a recent multi-center registry study from Germany, from Jörg Heil's group, 13,700 patients eligible according to C11 criteria. And in these patients, the use of axillary dissection decreased from 95 to 47%, a major change in clinical practice on one side. On the other hand, many of those 47% of patients could have potentially been spared the morbidity of axillary dissection if the C11 protocol had been applied even more rigorously. So what are the current indications for axillary dissection? Palpable disease in the axilla in the upfront surgery setting. residual disease after neoadjuvant chemotherapy, locally advanced breast cancer, and sentinel macrometastasis in a patient undergoing mastectomy. But only if that one positive sentinel node does not make your radiation oncologists indicate post-mastectomy radiation. If the patient receives radiation and it includes the nodes, you do not need to go back and perform axillary dissection. Radiation will take care of it. So why do we know that radiation is not less effective than dissection in these patients? These are long-term follow-up data from the EORTC AMROS trial that Emil Rutgers thankfully let me show here. He showed the data a few months ago at San Antonio. Now in this trial, more than 1,400 patients, 250 of them underwent mastectomy, clinically node-negative, sentinel positive, were randomized again into dissection, compared now to axillary radiation. Again, extremely low rates of axillary recurrence with no difference between the groups, making the point that radiation is not less effective, it probably causes less harm. What about this one patient that has this one positive node on the ultrasound? Can you still apply C11, or do you need to proceed directly to axillary dissection? This has been looked at by this meta-analysis of 6 studies, more than 4,200 patients, and in patients where the disease was detected only by ultrasound, 43% of them still had only 1 or 2 positive nodes, still qualifying for C11. So if you proceeded directly to dissection, you overtreat almost half of those patients. We will also soon have randomized data or data from randomized trials to address some of these open questions. The upper trial, XENOMAC, includes also patients who are with imaging detected disease and patients with positive sentinel nodes undergoing mastectomy. The lower one, the FREDGE trial, includes also the latter patients and patients with more than 2 positive sentinel nodes. Those are trials similar to C11, but with extended eligibility criteria. And as you can see, XENOMAC on the right side accrued already more than 1/3 of patients. It's well underway, and the French trial almost completed accrual. So with a few years of follow-up, we will know. So what about the high-risk end of the spectrum of patients with positive nodes? Residual disease after neoadjuvant chemotherapy. This question has been addressed, or is currently being addressed, by the Alliance trial that randomizes clinically node-positive patients that turn into clinically node-negative after neoadjuvant chemotherapy and have residual disease in the sentinel nodes into the dissection group compared now to an axillary radiation group in the context of extended regional irradiation. As you can see, accrual has almost been completed. And we have now started the TAXIS trial in at least 40 centers in at least 4 countries. This is a collaborative effort of the SAKK, the IBCSG, the ABCSG, and now also the German breast group. In this trial, we question the paradigm that palpable disease in the axilla by reflex requires either neoadjuvant chemotherapy, irrespective of biology, or radical axillary dissection. In this trial, we basically challenge this paradigm that this is necessary. This never made much sense to us because palpable disease, by definition, is the easiest disease to localize and remove in a selective manner. You can just use your finger. You don't even need imaging. So we hypothesize that tailoring the extent of surgery to the extent of disease in the axilla in combination with radiation is not less effective than radical axillary dissection. So what can you do today to omit axillary dissection in a patient with palpable disease in the axilla? The only way is to perform neoadjuvant chemotherapy and achieve pathologic complete response in the nodes. Now, how can you reliably determine that the nodes are clear without removing them all? The sentinel node is one option. This meta-analysis has included 13 studies, almost 2,000 patients undergoing the sentinel procedure, and then axillary dissection. The identification rate was 90%, the false negative rate 14%, which could be reduced to 11% with dual mapping and to as low as 4% when at least 3 negative sentinel nodes were removed. Are there alternatives to the sentinel? Yes, there are. This is another recent meta-analysis looking at this question, and on top you see that 2,000 out of the 2,200 patients were treated with the sentinel only, so that's where we have most experience. These are the same patients like in the slide before, so the numbers are very similar. But there is also the option of the MARI procedure, marking of the axillary lymph node with a radioactive seed before neoadjuvant chemotherapy, and then selectively removing it after. Only one small prospective study, but very promising characteristics, 97% identification, 7% false negative. So this is already being implemented at some centers in the Netherlands. Now you can selectively remove, first localize the initially positive node with a clip and then selectively remove that in combination with the sentinel procedure. This is a procedure called TAD, targeted axillary dissection. 2 studies, 120 patients, very promising performance characteristics. So this is probably a good way, and we like to do this in our hands, but as soon as you start marking that positive lymph node with a clip before neoadjuvant chemotherapy, you have to make sure that that clip comes out during surgery. Otherwise, if that patient recurs, you're going to be the surgeon who left cancer behind. And how often can you not retrieve that clip? This is the primary question of a prospective registry study from Germany, from Scherko-Kümmel. 600 patients, recruitment has been completed. We are awaiting the data. Other studies have suggested that this may be a substantial issue. So let's focus on the use of the sentinel, because this is already being done in this setting. This is a series from Mayo, 430 clinical node-positive patients undergoing neoadjuvant chemotherapy during 9 years. The use of the sentinel in these patients increased from 28 to 86%. The use of dissection decreased in these patients from 100 to 38%, a major change in clinical practice, and Monica Morrow's team has published similar numbers as you've seen in her talk 2 years earlier than that. The jackpot question here, however, is, does the false negative rate matter in the neoadjuvant setting? Do those patients recur more often, since this is chemo-resistant disease left behind? There are not many series. This is one from Vienna, from Milan, 70 patients initially clinically node positive, undergoing neoadjuvant chemotherapy, turning into clinically node negative, having a sentinel which was negative, so no dissection was performed. And even though they used a single tracer, and even though they considered isolating tumor cells as sentinel node negative, at the median follow-up of 61 months, there was not a single case of axillary recurrence, so probably the procedure works. The final question we're going to address, what do you do with micrometastases in the sentinel node after neoadjuvant chemotherapy? A series from Sloan Kettering, 700 patients, and they found that in patients with micromets, 59% had additional positive nodes removed by dissection, compared to 63% in patients with macromets. So in the neoadjuvant setting, low volume disease does not indicate a low likelihood of having additional positive nodes, so axillary dissection should remain standard in these patients. And now let's switch gears and get to surgery of the breast. Just a few words on margins. The seemingly endless debate on what constitutes a negative margin for invasive cancer in the adjuvant setting has been ended after publication of this meta-analysis of 33 studies, almost 30,000 patients, showing that margins still matter, but there is no evidence that a margin wider than no ink on tumor further decreases local recurrence risk. So this definition has been endorsed by SSO-ASTRO, ASCO, ASBS. And enough time has passed to look at the impact of this guideline on clinical practice. This is a very recent meta-analysis of 7 studies showing in the US that the prevalence of re-excision dropped from 22 to 14%, with an odds ratio of re-excision after guideline publication compared to before guideline publication of 0.6, so a 35% lower odds of re-excision after compared to before guideline publication. Again, a major change in clinical practice. What do we know about margins in the neoadjuvant setting? Not much. We need much more data on this. We have some single-center retrospective observational studies, like this one from Terry King, 380 patients, stage 1 to 3, undergoing neoadjuvant and then breast-conserving therapy, showing very high rates of local recurrence-free survival of above 96% at 5 years, with no difference in patients with margins of 2 millimeters or below compared to more than 2 millimeters. So we think, and the authors concluded, that no income tumor may suffice for many of these patients. But again, we need more data. And why is it so important to minimize local recurrence risk after neoadjuvant chemotherapy? This is an individual patient data meta-analysis of the early breast cancer trialists collaborative group, comparing the neoadjuvant with the adjuvant setting, almost 5,000 patients from 10 trials. And what they showed at 15 years is a more than 5% higher risk of local recurrence in the neoadjuvant setting compared to the adjuvant setting, 21.4 versus 15.9%. Now, in these types of studies, you can always argue that these results are not applicable anymore to today's patients with today's treatments, but they certainly do call for caution. So what can you do besides narrowing margins and downstaging locally to increase your rates of breast conservation? You can eliminate contraindications like multicentricity or multiple ipsilateral breast cancer. This is a topic repeatedly being addressed at St. Gallen. The last time, 2 years ago, 2 out of 3 panelists said you should try breast conservation as long as margins are clear and radiation can be performed. We now have prospective data to support this recommendation, almost 200 patients, and breast conservation was feasible in 1 operation with clear margins in 2 out of 3 patients with low rates of conversion to mastectomy. And a randomized trial is planned in the field. One way to perform large volume resections for multicentric cancers and still achieve good aesthetic results is oncoplastic surgery. We now have several series with long-term follow-up data. This is one example, 350 oncoplastic reduction mammoplasties for large tumors showing low rates of positive margins, surprisingly low rates of complications, and low rates of recurrence. So this is oncologically safe. Oncoplastic surgery can be taken as an alternative to mastectomy. The most important question in the field of oncoplastic surgery is, does this escalation of surgery that improves aesthetic outcomes when measured objectively also translate into a better quality of life? And can we measure that? 2 different questions. And this panel of experts from the German-speaking societies of Senology recommended 2 years ago with a strong consensus that we have to start asking this question to our patients. We have to start including patient-reported outcome measurements as a standard for outcome assessment after oncoplastic surgery. To further enhance or advance in the field of oncoplastic surgery, we have founded the Oncoplastic Breast Consortium. I announced this 2 years ago during my talk here for the first time. It is now a global consortium. We have surgeons and many patient advocates from 62 countries. We do perform consensus conferences and research projects and promote high-level education. And one of the main conclusions of last year's consensus conference was that there is a major heterogeneity in breast reconstruction practice after nipple-sparing mastectomy and immediate reconstruction. There is not really much of clinical equipoise because the opinions are very strong. Every expert knows to the last detail what's best. The opinions are just very discordant. So we do not know what's best. Autologous versus implants, pre versus subpectoral positioning of implants, 1 versus 2 stage, mesh versus no mesh, biological versus synthetic mesh, and many more open questions. So as a first consequence, we have developed the OPBC pre-pec trial protocol. We plan to randomize patients into a pre versus subpectoral positioning, and we have started a consensus conference to identify research priorities in this field. The Delphian preparation will go out in 2 weeks. The whole OPBC, the whole consortium will be involved. And this is my last slide. I'm good in time. Why is it so important to generate high-level evidence in this field? This has been shown impressively by this small but important study from the Netherlands that hit the Lancet Oncology hard and twice in the past 2 years. They randomized 142 patients undergoing skin-sparing mastectomy into a more modern type of reconstruction, direct to implant or one stage, with the use of acellular dermal matrix, ADM, a magic device. You can do everything with that device. It's a multi-million-dollar industry. And they compared this to the more conventional two-stage or expanded to implant reconstruction. 142 patients at 1 year, no difference in quality of life, but there were serious safety issues with this more modern type of direct-to-implant reconstruction. More complications, more reoperations, more losses of implant or ADM or both. Now, several experts, and we have discussed this intensively during another beautiful Vienna breast surgery day yesterday, many experts criticized there was a lack of experience and expertise in this study with this more modern technique of direct-to-implant reconstruction. But my opinion on this is we have to be careful when we introduce new surgical devices or new surgical concepts into surgical practice, because in the end we all committed to first do no harm. Thank you very much for your attention.
Thank you, Walter, for being able to cover the breast and the axilla in 20 minutes. We have time for 1 or 2 questions. We have 8 microphones. There is one in the back, number 8. Please identify yourself with name and institution and ask your question.
Jonas Berg from the Karolinska in Stockholm. Thank you for this thorough lecture. I would just like to comment on one of your slides, namely when you quote in the early breast cancer trialist collaborative group, you rightly state that there was an absolute increase in local recurrence if you were running neoadjuvant therapy, but there was absolutely no difference in distance recurrence, breast cancer mortality, in overall mortality. So my question to you, couldn't you think that due to that you have a high chance of breast conservation, that some of these so-called recurrences are new cancers, as you can have on the contralateral side? You have more breast tissue remaining, and accordingly, that's another theory, because if there were true recurrences, that would have impacted on the patient's survival expectation, but it didn't.
Right, so I absolutely agree. There were no differences in this trial in any other type of recurrence than local recurrence or new second primaries in this breast. We treat them as the same. Clinically, we don't make much of a difference in terms of treatment between the two entities that you have mentioned. So it is possible that there are more new primaries after neoadjuvant compared to the adjuvant, but I wouldn't be aware of any clinical consequence of that hypothesis.
Okay, thank you. I have one question. So no ink on tumor, no tumor on ink. It's easy said, easy written. What about the patients which we have always in our tumor boards? They have a focus. Like in the lobular, there is 1 or 2 Indian files with one cell touching. Would you think it is worthwhile to take the patient back to the operating room? And is there data for that?
I'm not aware of any solid data to address the focally positive margin. I'm not aware of any opinion leader moving away from the guideline of tumor not touching ink. So in most of these patients, as per standard, probably re-excision should be evaluated. However, we all know that in the individual patient, with only this 1 or 2 cells touching the margin, there are many things we will take into regard. Age, size of the breast, can we do a re-excision, risk of recurrence in general, of course always patient preference, so we will decide this in daily practice on an individual basis, but it never made it into any guidelines due to lack of data.
Thank you. Okay, the last one, number 1.
Linetta Koppert from the Netherlands. Well, in the Netherlands, it is in the guideline that it is safe to do no re-excision in focal radical results. And we've proven it's safe, so maybe we should go that way.
Okay, we will deal with it in the manuscript. Thank you.